Good evening for all speakers and audience. In the name of the Brazilian Society of Cardiovascular Surgery, Dr. Carlos Brandão and I will moderate this webinar that will bring us a current and very important theme: structural heart disease cardiac surgeon approach. First, I'd like to thank all speakers for the presence in this web meeting. They are very important surgeons with large experience in this issue. A quick instruction for the audience: the chat is disabled and all questions must be submitted using the Q&A link. To start, I'd like to introduce Dr. Isaac George. Dr. George is Surgical Director, Heart Valve Center at Columbia University in New York. And he will talk about key considerations to support therapy decision process. Dr. George, please.
Okay, thank you very much. It's really a pleasure to be here today. I want to thank the organizers and I want to thank Edwards for allowing me to present. Mine is an open presentation. I'm going to be talking about decision-making in aortic valve disease, and this is a new topic. This is something that changes every few years with the advent of new technology, new data, and new trials. And so what I'd like to do is make it concise and try to understand how we as surgeons can help guide this process and make informed decisions. I think you may have seen some of these graphs before, and these are the graphs of the numbers of TAVR and SAVR that are being performed in the United States right now. As you can see, the number of TAVR has increased dramatically over time. And by 2018, 2019, we've have almost 2 to 1 to 3 to 1 numbers of TAVR over isolated AVRs. And you can see here that the estimated risk shows that almost 75,000 to 80,000 will be performed in 2019. And this is the graph that a cardiologist will present. But in reality, when we look closely at the data for 2018, you can see that actually AVR is still alive and well in the United States. When we look at all aortic valve surgeries that are occurring in the United States, and that includes Bentals, that includes valve cabbages, that includes other cases, you can see that AVR as a total volume has actually stayed relatively constant from 2012 to 2018. There's no question that isolated AVRs have gone down and will continue to go down. And isolated TAVRs, meaning TAVRs that are being performed solely for aortic stenosis, has increased dramatically from 4,000 cases in 2012 to now 75,000 cases. And that's inclusion of high-risk populations that we weren't treating before that we're now treating. We expect TAVR to be almost 100,000 this year if it wasn't for COVID. But I think aortic valve disease is very well treated with surgical therapies, and that's an important concept to remember as surgeons, that we have in our hands probably still one of the best and most reproducible and reliable therapies out there. When we look at surgical valves, we have a number of valves that we can use. We look at stented valves that are bioprostheses. We look at rapid deployment bioprostheses. And then we also have transcatheter valves, which there are a number of and increasing as we speak. I haven't even included the mechanical valves because mechanical valves have a number of other considerations and are oftentimes in populations that are different now than tissue valves. And we'll get to that as well. The challenges for an aortic valve followed the same basic commandments that they did in the 1950s as they do now. They must not form emboli. They must be inert and not damage blood. They must offer no resistance to flows. They must close. They must open. They must last. They must have normal anatomy. They must fix in place. They must not annoy the patient. They have to be technically practical to insert. These hold true for transcatheter valves, and this holds true for surgical valves. When we think about common issues that we face in 2020, they come down to infection, thrombosis, calcification, deployment. We have a lot of these things that we've considered and we're able to do very well, but we still have some of these persistent issues that we have to deal with as surgeons. The informed choice, and this is a patient decision, and we come to realize this now more than ever when patients have choices to make between TAVR or SAVR. Patients make a lot of these decisions, and patients are choosing tissue valves. Patients are not choosing mechanical valves. Very commonly, when you're a 50-year-old and a 60-year-old, when you talk about the longevity of valves, that doesn't actually play that much into their priorities, and it really comes down to the options of using Coumadin or not using Coumadin. And so you can see the preference for patients has strongly been for tissue valves. That being said, if you look at the survival curves for patients who have biologic valves versus tissue valves are still very good for mechanical valves. And you can see that over a period of time at the level of reintervention at 12 to 15 years, those curves may actually favor a mechanical valve. Yet patients still refuse to take Coumadin and choose tissue valves. So we have a decision to make, and we have issues that we're going to have to deal with. When we look at patient populations who have aortic valve disease, who get AVR, the large majority of them fall within the age of 55 to 75. And so if we understand that a tissue valve, which is what 90% of these patients are choosing, will last 12 to 15 years, we're going to have a lot of patients that are going to need reinterventions. And so we're going to have to be able to deal with that. So size matters. Sizing affects whether TAVR or SAVR should be the first intervention, and that's one of the first concepts that I'm going to introduce. A valve-in-valve is a great option for dealing with a degenerated surgical valve. It makes sense, it's intuitive, it's easy to do. It's really become the first option for patients that are high risk, and this is very clearly seen in patients who have had repeat procedures from the VIVID registry, which is a TAVR valve-in-valve registry. You can see that the majority of these patients had valve failure at 9 to 10 years. Current indications are for failed aortic valves who are either high or intermediate risk using either a self-expanding or a balloon expandable system. And that correlates to a patient that has an STS greater than 3 to 4%. So that's actually not that high. That qualifies for most patients. Again, no incisions, no sternotomy, they're walking that day, no time on the ventilator, very little bleeding. It's technically doable in over 95% of patients. The durability is still the question. We do these patients awake. We sometimes send them home the same day, and it's a nice way to extend the life of a surgical tissue valve. It's very important to understand all the tissue valves and the anatomic characteristics of each bioprosthetic valve. The manufacturer's labeled valve size does not match any actual relevant hemodynamic dimension. It usually corresponds to the outer base diameter, which corresponds to the stent frame, or B in this figure here to the right. The external sewing ring is actually not even correlating to anything from a numerical standpoint to a surgical size, but it's actually the internal diameter, which is the abbreviation A, the valve leaflet, which is really the actual internal dimension that's most relevant for valve-in-valve therapy. And these are, again, much smaller than a labeled valve size. Why is that so? It's because the actual stent frame and the leaflets take up space in the inner orifice, which again, reduce your effective orifice area. You can see for porcine leaflets mounted inside, it can take up to 2 millimeters of a diameter. For a pericardial valve, it's 1. For a valve that's with the leaflets mounted on the outside, such as a stentless valve, these will actually retain its true ID. And you can see that these are the numerical values of reductions of effective orifice area and a stent ID that occur with these different kinds of valves. So it's critically important to understand and to know the anatomy for each of these valves. These valve characteristics can be found from reference tables, but the easy way to do it is to go on the valve-in-valve app. And this is an app that you can get on your phone. This is made by one of my close friends and colleagues, Vinny Boppet, and this is a great way to size valves. We also use CT scans. CT scans are immeasurable. As a surgeon, it's imperative in this day and age to know and understand every single aspect of a CT scan for a patient who's getting even an initial aortic valve operation. CT scan will give us the annulus area, the annulus perimeter, the heights of the coronaries, the sinus size, the sinus widths, the ascending size, the STJ size. This gives us the angulation, and these are all critically important to not only know what size surgical valve we get in, but what size transcatheter valve. Are we able to do a transcatheter valve-in-valve afterwards? We have to be careful with certain valve types if we put them in terms of their candidacy, if they're going to be able to get a valve-in-valve afterwards. These are stentless valves, the trifecta and the MitraFlow. They have very high coronary heights and the coronary obstruction rates are much higher. When we talk about the 3F aortic bryoprosthesis, this was also a very high mounted stent frame, which had tabs that resuspended these leaflets. These are very challenging cases to do valve-in-valves in. This will change our initial approach to surgery. And this is what patients ask. When I have my initial operation, can I get a valve-in-valve afterwards? Will this prevent me from having reoperative surgery? Can it delay reoperative surgery? And the answer is yes, undoubtedly. So let's ask a different question. How durable does TAVR actually need to be? Because as surgeons, sometimes we say, oh, well, TAVR is never going to last. But let's see, how long does it really need to last? If you're 70 years old, according to life tables in the United States, if you're a man, you're going to live approximately 11 years. But if you're a female, you're going to live 13. So again, good to be a female. Let's go to age 80. If you're 80, you know, you're a man, you're going to live about 6 years. You're a female, you'll live 7.25 years. So we need to make sure that the therapy is concomitant to however long you're going to live. And that's an important question to ask. Not the question, is SAVR more durable than TAVR? It's not a competition. What it comes down to is we have two different therapies, and we need to be able to use both of them to treat our patients. And that's a really key fact. We don't want to get into a bidding war between CABG and PCI like we had before in the past, or we're going to hurt our patients. The correct question is not, is SAVR more durable than TAVR? That's actually not the right question to ask. We don't really need to care if SAVR has a longer valve durability than TAVR. What we need to do is we need to figure out how can we minimize the number of sternotomies or major risk operations or major risk interventions for patients. So let's do this by playing out some scenarios. So we have a 55-year-old man who has severe AS, a tri-leaflet valve, and a 23 annulus. That's actually a relatively small annulus. You can maybe do one valve-in-valve, but you're not going to get away with, you know, an extra valve-in-valve. You're not going to be able to do two. So let's say you do surgery at 55. At 70, that valve gets old and you do a TAVR valve-in-valve. And then at 78, you think a valve-in-valve lasts maybe 8 years. And that's being generous, by the way. Then you're going to have to do a resternotomy on him at 78. And then that lasts another 15 years. And then, you know, when you're 90, you can get a valve-in-valve again. So, okay, that's 2 operations. When you're doing TAVR first, you do a TAVR. And at 10 years, you do a sternotomy, AVR. And then you do a TAVR valve-in-valve when you're 80. And then you do a valve-in-valve times 2 when you're 88. So you can get to 88 years old with 1 sternotomy in the second scenario. So is that the future for tomorrow? And is that something that we should be thinking about today? It's possible. We have to consider it for certain patients where we do TAVR, then valve-in-valve, then SAVR, and then valve-in-valve afterwards to minimize the number of sternotomies. Let's change the scenario though and go to a 70-year-old, same patient, same anatomy. If we do surgery at 70, AVR, then we do TAVR valve-in-valve 80, 85, 93, you know, 100, we give them a big party and a glass of wine and, you know, say good job. But at 70, if we do TAVR first and it lasts 8 years and we do TAVR valve-in-valve that lasts 5, 7 years, we're looking at a sternotomy at 83, and then that lasts however long. If I'm this patient, I want the first procedure. I want surgery at 70 because I'm going to be a lot healthier at 70 getting surgery than I am at 83. So there's no question about that. I want to avoid sternotomies and surgery, cardiac surgery, when I'm in my 80s. There's a sweet spot for TAVR. So if you're in that sweet spot, I think it's going to be great. But if you're not, I think SAVR may be a better option. So we need to be careful. And the real elephant in the room, and I've taken out a number of TAVRs, and some of them can be very challenging, some of them can be very straightforward. Not all of them have needed routes, but we're going to have to figure out how difficult is it going to be to take these out? Do we have to do a route every time that we remove a valve? And if that's the case, then maybe we won't be doing TAVR valves as our first initial procedure. So in what situations do I prefer TAVR? Porcelain aorta, clearly small patients with a small BMI, small patients with a small annulus, very obese patients that are high surgical risk, high BSA that I'm going to get PPM on. Older obese females. Old obese females don't do well with surgery. I like doing TAVR on them, and I think that's a good option. In general, females do much better with TAVR than they do with SAVR, and that's something that we figured out from randomized trials. Patients with lung disease. In terms of guiding principles, if you're 70 years older and you have good anatomy for a valve-in-valve, then TAVR is going to be a good option for you. And if you don't have good anatomy for a valve-in-valve, I move that age group up to 75 or so. I really have to get the patients to their mid-80s without doing surgery in general, if I'm going to be doing TAVR. So SAVR can be everyone else, right? And these are in general patients with a high activity level, a good size annulus, fit active patients, patients with coronary disease, patients with multivessel disease, severe LVOT calcium that we're not going to get a good seal for, obese patients that are young, that are willing to get a mechanical valve, patients that are high risk for reoperations, who you can get a mechanical valve in. Bicuspid valves, most bicuspid valves are going to be best treated with surgery. And I want to plan, if I can, to do one sternotomy over a lifetime using the technologies that I have, which include TAVR and valve-in-valve. I don't know what's better for a young patient with a porcelain aorta who's had mantle radiation. Maybe I should do TAVR for a short term and then do a mechanical valve and take everything out, or a degenerated valve in a young sick patient or an end-stage renal patient. The impact of patient prosthesis mismatch is very important, and we know that it suggests that it can affect outcomes. And there's no question that PPM seems to be much less in TAVR than in SAVR. And that's because the area is much bigger. But when we look at valve-in-valve procedures, the biggest prognostic factor for getting PPM is a small surgical valve. So we try to do root enlargements in surgery to prevent that. But one of the things that we can do is to fracture surgical valves. And this is where we take a high pressure balloon and actually take a Kevlar balloon and actually bring it to a pressure that actually breaks the basal ring of these surgical valves. It allows for a larger expansion and a larger transcatheter valve to be placed with better hemodynamics and better effective orifice area. You can see here, this is a magna being fractured with a true balloon, which is a non-compliant balloon. You can see the basal band broken right underneath the strut there. And we have tables that show which valves can be fractured and which can't. Two valves cannot, are the Avalus and the Hancock. And we can remodel other valves such as trifecta, the Edwards Standard, the old CE 2700s. And so we know what we can do. I'm going to skip over this slide, which is a technical slide on sizing and what balloon sizes we should do based on the stent ID and the balloon. But you can see here that this isn't without some risk. Obviously, you can actually tear this frame and you can even cause annular damage, and this can stick out. And this is a case report of a patient that had annular injury. We've had one annular injury. We've had balloon ruptures. One had a stroke. We've had severe AI. We've had debris that have come off from the valve as well as from the annulus, higher pacemaker rate potentially. So it's not benign. This is where Edwards has actually made a brilliant invention and product design with the Inspiris valve. This valve has what's called the VFit technology, which are interlocking metal frame that can slide and open up, and that allows the valve to expand with a very compliant balloon and allow a greater transcatheter valve to potentially be placed inside. And you can do that without fracturing. And so it potentially allows for a safer valve-in-valve procedure with a larger valve that can be placed. And that's a very important concept. And we've been using this valve without any failures pretty routinely at our center for the last 2.5 years with excellent results, with the understanding that hopefully in the future we'll be able to facilitate valve-in-valve. So how do we finally make decisions regarding valve therapy? We have to know the exact anatomic information for every single patient undergoing TAVR or SAVR. It's on us as surgeons to know this. Every patient with aortic valve disease needs a dedicated TAVR protocol CTA. We have to understand and plan for every intervention for the rest of every patient's life. Current therapy has huge implications on future therapy. personalized decision-making leads to better outcomes. Thank you very much, and I look forward to the discussion.
Thank you, Dr. George, for your nice presentation. Let's move on. The second speaker will be Dr. Fábio Gaiotto. Dr. Fábio Gaiotto is a cardiovascular surgeon, coordinator of surgery treatment unit at cardiac insufficiency at INCOR HCF MUSP. Dr. Gaiotto will talk about new class valve Inspiris resilia, case presentation and discussion. Dr. Gaiotto, please.
Thank you. Thank the Brazilian Society for the invitation to participate in this very nice webinar. Thank you for Edwards to invite me to get together with us. Congratulations, Dr. Isaac. Very nice presentation. And my presentation is a short presentation, and I will show you a case, a real case for our day-by-day practice, a case report. That is a patient, a male patient, 41 years old, and I'm a horse polo player, a very athletic patient. And he has a history of shortness of breath, mostly with great exercise, that began 2 years ago with worsening in the last 3 months. It's important to say that the patient plays horse polo till 2 months before came to our evaluation and to receive our indication to do the procedure. The patient had no other medications, no other conditions of sickness, a very healthy patient in other organs. And this is the chest ray showing us a very large cardiac area, suggesting a left ventricular enlargement with a very big cardiomegaly. And the transthoracic echocardiogram evaluation showed a thickened aortic valve, like a rheumatic disease, but the patient shows a very poor history from rheumatic history in the infant that not suggests strongly this disease, but the echocardiographic showed a rheumatic aspect and a valve, three-leafed aortic valve. And the transthoracic showed a severe aortic valve regurgitation with left ventricular enlargement. Mitral, pulmonary, and tricuspid valves are normal. The ejection fraction was 65%, is preserved the ejection fraction, and the left ventricle dimensions was the end diastolic diameter is 63 millimeters, and the systolic diameter is 39 millimeters. Normal aortic root size. This is an image showing the very large the orifice from regurgitament, suggesting a retraction on the leaflets from the aortic valve. The eject it's very important, the insufficiency, the aortic regurgitation is a very big with a paradoxal pulse in descending aorta. And the patient, after left my evaluation, went to a second opinion at Mayo Clinic in the United States, and the echocardiogram evaluated the same thing, and they suggested the same valve that we put here in Brazil. And for the patient returned to do the operation here with us. This is the kind of life that our patients are very strongly patient. It's not the patient, but the sport that patient performs this. And the option from the patient is none or minimal change in his lifestyle. He wants to perform this sport after surgery, after recovery very well. And we discussed a lot of decision make to which valve we need to put, because the patient is very young and very healthy. And I believe that if one can choose the valve prosthesis, one will say one valve for life. Is the same thing that Isaac told us, to try to take the life of patient till 78 years old. And we discussed with heart team, is a decision making with cardiologists, surgeons, interventional cardiologists to discuss different cases, but not in this patient because he's a very young patient. Anesthesiologists to perform the perfect analgesia and quick intubation in the post-operative period. And the heart team has one common purpose: do the best for the patient with low or no changes in quality of life. The decision making, Isaac showed us in a very detailed presentation before, but I insist that the choice of type of prosthetic heart valve should be a shared decision making process that accounts for the patient values and preference, and including the distribution, indication, and the risks of anticoagulant therapy. And this patient avoid the use from anticoagulant therapy, and we do not use mechanical prosthesis for this patient because the patient don't want to use oral anticoagulation. And this presentation shows that between 50 and 70 years of age, the decision making is difficult, is favorable for bioprosthesis, and the patient, when is more young than this, a mechanical prosthesis is considered in some cases that the patient wants to accept the anticoagulation therapy. This presentation shows in the guideline that a bioprosthesis is recommended according to desire of informed patient. This algorithm shows an easy way to choose the bioprosthesis or mechanical prosthesis for patient. And our patient is a very young and no anticoagulation is necessary to perform this kind of sport of this patient wants to do. So we decided to perform an aortic valve replacement through median sternotomy, and a median sternotomy with a small open in the skin, but a median sternotomy because it's stable to recuperation and do not do pain with fractures on symmetry as equal in this side of left and right, and perform a stable to thoracic for patient to practice sports. And normal thermic cardiopulmonary bypass and a 49 bypass time, 32 minutes clamp time. We use antegrade del nido cardioplegia, and we choose for this patient and prosthesis Inspiris 27 size because it's a very big annulus. This is easy to perform this operation. The patient is tubated in operative room with no problems, 5 days to discharge home. The gradient, mean gradient in postoperative echocardiography shows a mean gradient of 9 and peak in 13, a very low gradient. And Isaac showed us that the VFit technology permits a valve-involving filter 2 times when the annulus is very big, when the valve size is big. And we believe with this procedure, we can do a very good healthy for the patient and still be older with 2 TAVs in the future. So take home message from a short presentation is surgery must be well discussed and indicated with a heart team procedure. We must aim very long-term results with very quality and style of life matters for the choice from the valve for each patient. And sorry, my English is not so good, and wait for answers after. Thank you.
Thank you, Gaiotto. Now we will introduce our third speaker. Is Dr. Sérgio Lima de Almeida. Dr. Sérgio is professor of cardiovascular surgery at Unisul University. He's also chief of cardiovascular surgery at SOS Cardio Hospital at Florianópolis, from Santa Catarina. He'll talk to us about rapid deployment valve, Edwards Intuit Elite, case presentation and discussion. Please, Dr. Sérgio.
Okay, thank you so much. Good evening to all. Initially, I would like to thank the Brazilian Society of Cardiovascular Surgery and Edwards for the opportunity to discuss this topic with you. It's an honor to me. The subject that was proposed was the presentation of a typical case for rapid deployment valve with the Intuit valve, highlighting its most common indications. We are not going to discuss here the literature because it's not the purpose of this presentation. We have some experience with these valves in our hospital. It has been consolidated for cases of associated surgeries in patients at increased risk, also for patients with a minimal invasive approach, and for patients with a small aortic annulus, avoiding the need to enlarge it. There is an increasing number of publications consolidating the safety and excellent results with this type of valve, but we need even more randomized studies comparing these valves with conventional surgery and TAVR. Let's go to the case. This is my disclosure. I am Intuit Proctor. We are going to show you a 72 years old gentleman with a past medical history of essential hypertension and dyslipidemia. The patient claims to be entirely asymptomatic, although his wife notes that he has decreased his physical activity over the past 2 years. Last January 2020, he has a syncope episode. The investigation discovered severe aortic stenosis with surgery indication. In the first stage, after the diagnosis of severe aortic stenosis, he declined to continue the investigation and refused any approach. 1 month after the syncope episode, he starts with classical angina episodes very often. Then he decides to investigate and treat. Here is the physical examination, the laboratory data, and the medication. The most important thing here is in the laboratory data, the creatinine level of 2.1. The electrocardiogram, normal sinus rhythm, and left ventricular hypertrophy. Transthoracic echo. Severely calcified tricuspid aortic valve with a valve area 0.8 by the continuity equation, mean gradient 46, Doppler index 0.17 associated with a severe aortic stenosis. Below 0.25 it is severe. The aortic root is normal size. Left ventricular ejection fraction was 59 and moderate left ventricular hypertrophy. Mild pulmonary artery hypertension. Mild left atrial enlargement. Calcification in the mitral annulus and mild mitral regurgitation. Here, the preoperative echo showing the peak gradient and mean gradient. 68 the peak and mean gradient 46. The CT, focal ecstasy of the proximal descending thoracic segment, which reaches a maximum transverse diameter of 4 centimeters without a configuring aneurysm. Anatomical supraortic truncus with no area of stenosis or significant dilatation, extensive aortic valve calcification, and important coronary atheromatosis. Here, other measures. You can see. Okay, the angiography. Left main normal, left anterior descending artery large, 90% proximal calcified stenosis, and mild and in the mild portion. First diagonal large branch with 90% proximal calcified stenosis. Left circumflex artery, 80% proximal calcified stenosis, and the third branch, it's very large, occluded proximal with a collateral perfusion. And the right coronary artery, large, with 95 ostium calcified stenosis and mid portion, and 70% distal calcified stenosis, with good distal landing vessel. We have a heart team in our hospital. We discuss the case in the heart team. The EURI score 1 is 5, the STS score 2.57. According to the analysis extracted from the latest European guidelines, the following items are favorable to surgery compared to TAVR. STS score below 4, EURI score 1 below 10, age less than 75 years, and severe coronary disease requiring myocardial revascularization. This is the guideline that we use to decide the cases in our heart team. Okay, this is the perioperative TEE showing a very calcified tricuspid aortic valve here. The surgery. Aortic valve replacement, we use the Intuit 23 and 5 bypasses. The aorta and right atrium were cannulated, and the patient was cooled to 34 degrees centigrade. Arrest was achieved with antegrade cardioplegia, custodial. First, we proceeded the aortotomy, hoistic, and removed the very calcified tricuspid aortic valve. Then we sized the valve and choose a 23 intuitive valve. After that, before the aortic valve replacement, we performed the distal anastomosis. I prefer this kind of approach because I save time while the valve is prepared. We use 2 memory arteries, 1 radial and 1 saphenous vein by the no-touch technique. The Lima was grafted to LAD. The Rima was grafted to the first diagonal branch. The radial artery was grafted to the descending posterior branch. And the saphenous vein grafted sequentially the first and third obtuse marginal branches. We implanted the intuitive valve with a 4.5 ATM during 10 seconds. After we removed the cross clamp, the sinusal cardiac rhythm returned. Then we stopped the cardiopulmonary bypass in a stable hemodynamic conditions. Clamp time 99 minutes, cardiopulmonary bypass 105 minutes. Reduction 32%. We had 32% reduction in time when we compare with similar cases using conventional valves in our hospital. This is the intraoperative TEE showing a very nice area, 2.1 centimeters for a 23 valve. This is a 3D intraoperative view of the prosthesis. This is another intraoperative view showing no paravalvular leak. Intraoperative mean gradient 8 and peak 15. Postoperative course. Postoperative course was uneventful, extubating after 4 hours, discharge from ICU on 3rd PO, discharge home 8, and 3 months echo follow-up, same gradient. Here you can see the echo with almost the same gradients of the intraoperative echo. We have 98% follow-up of our cases. We performed a TTE echo at 3 months and at 1 year. And the results found so far are the same as in the literature, with maintenance of the gradients. Discussion, hub deployment advantage. Reduce cardiopulmonary bypass and cross-clamp time, very low rates of paravalvular leaks. In our experience, if you respect the sizing, the incidence of paravalvular leaks, it will be very low. Option for combined procedures, most important in high-risk patients. Our average EURI score was 6.7. Optimal for minimal invasive procedures, reducing even more the cardiopulmonary and clamp times in the minimal invasive procedures. low gradients, even in small size. Our experience with the size of 19 and 21, the mean gradient was 9.1 intraoperative. Becomes an excellent option for small annulus avoiding PPM. Thank you very much for your attention. That's the case. Thank you, Dr. Carlos.
Thank you, Dr. Sérgio. It's a nice case and a very interesting presentation. Our next speaker is Dr. Cledicyon Eloy da Costa. He's a cardiovascular surgeon responsible for the transcatheter service and aortic endovascular treatment at Clínica Cardiocirúrgica from Campinas, São Paulo. Please, Dr. Eloy.
Hello, everybody. I would like to thank the Brazilian Society of Cardiovascular Surgery and also Edwards for the invitation for this to participate in this meeting. This is my disclosures for this presentation. Transcatheter aortic valve implantation has become a highly effective and beneficial treatment option for patients with severe symptomatic aortic valve stenosis. With that, a new era for cardiovascular surgeon has begun, and so new scenario has appeared with pre-procedure planning, procedure itself, and post-procedure. For TAVR, the most important, in my opinion, is the pre-procedure planning. The CT scan has assumed an important and complementary role in planning TAVR by providing some information such as the aortic root, the iliacofemoral morphology, and also the strategy. Also, the CT can give you some information and imaging that you can predict some complication that can be catastrophic during a TAVR procedure. So with that, I would like to present you a case of a 7-year-old man that came to our service with a New York heart function class 3, hypertension, history of cabbage in 2008, 3 grafts. All grafts were patent. I'm going to show you in a few moments. The creatinine level was 1.05. The echocardiogram showed a good left ventricle ejection fraction. The mean gradient pressure was 55 millimeters of mercury. The peak gradient, 96 millimeters of mercury. So it was a case of a severe aortic stenosis. The estimated risk, the early score was 5.3, and the STS score 4.1. As I told you, the CT scan can show you some information that can help you with the decision. In this case, that's the decision. It's a classic porcelain aorta, so it's a case of contraindication for surgical aortic valve repair. This is the CT showing the graft, the saphenous vein graft to the right coronary, right mammary to the circumflex, and the Lima to the LAD. You can see also calcification to the thoracic aortic arch and ascending aorta, and all the grafts were patent and doing well. So when you size the annulus, we always look for some image like this. That's a perfect image with no artifact. So it's a TAVR protocol with ECG synchronized in a systolic phase. We can always check if the image is in a systolic phase. You can see here the mitral valve. The mitral valve is closed, so show that we are really at the exact point to make the measurement. It's in the systolic phase. So when we measure the annulus, we have a maximum, the minimum, and medium annulus, so 23 medium, area of 426 millimeters square, and a perimeter of 750. Just remember, if you're thinking about a balloon expansible valve, you have to check the area, and if you're looking for an out-expandable valve, you're going to work with the perimeter. This is the iliacofemoral arteries showing some calcification, but not more than what we expect for this kind of patient, and the size of the vessels were good. And our operative plan was a transfemoral approach, right side for Edwards SAPIEN 3. That's the Edwards SAPIEN 3. It's a balloon expandable valve, a bovine pericardial tissue made. Size, we have to decide and check what the best size for this patient. When we look to the instruction for use of the sapien valve, and we have all these measurements, we're going to see that we are just here. We are in the border of two valves, 23 and 26. I'm going to show you here, it's better to understand. So we have an area of 426, so we are here, and the annulus medium is 23, so we are here. We're in the middle of between two valves. So when we look exactly specifically each one, we have the 23. We have for our patient, he has a native annulus of 426. If you use a 23 with nominal area, we're gonna have 4% of undersize after deployment. If you go to a 26 millimeter, we're gonna have a 21 oversize after deployment. So we always look for something close to 10% oversize depending on the amount of calcium we have. So, but if you look at this paper, we can change a little. We can use a 23 and add 2 cc, so we overexpand the valve, and this without compromising its performance. So if you use a 23 with plus 2 cc, we're gonna have a 6.5 oversize. That is quite good in our opinion. But I don't know, always we have a but, and it is just to remember the heroes of the Apollo 13 mission exactly 50 years ago in 1970, when the famous phrase, Houston, we had a problem, came, and that's a problem, a big problem. We have a narrow and calcified sinotubular junction. You see the sinotubular is narrow, 20 millimeters in diameter. And when we look at the recommendations for the implantation, when we have borderline cases, in special situations, you must use the smaller size, specifically when you have some case like this, narrow sinotubular junction and porcelain aorta. That's what we have here in this case. So which valve? No doubt that the 23 millimeters is the best one. But we still have a problem. When we look at the sinotubular junction, so it's a ring, it's completely calcified. When you look at the area of the sinotubular junction, we have an area of 367 millimeters. Remember that in our plan, we want to overexpand the sapien 3. So when we overexpand, we're gonna have an outflow 459. So this is in red. It's a simulation of the balloon at the sinotubular junction during the deployment. So if you use the balloon 2 cc added, we're gonna have 25% oversize at the sinotubular junction. It's a problem, it's danger. Maybe you're gonna have a aortic rupture. So it's just to illustrate, you can see how the balloon can fit at the sinotubular junction. It's the tail of the balloon. See, the main body has a 32 millimeters long, and this is the normal inflation volume in the instruction for use. So what's our operative plan? Our operative plan was a transfemoral approach, right side for Edward sapien 3, size 23 millimeters, and we decide to do the deployment in 2 steps, as we call 2-step deployment. That is, the first part, it's a normal deployment with a nominal volume. In the second part, we add 2 cc and reposition the balloon. I'm gonna show you here, that's the interoperator image. So you can see the aorta, ascendant aorta. You see the calcification is a huge amount of calcification specifically at the sinotubular junction. You see also calcium. This is the deployment with a nominal volume. You see it's under rapid pacing, the valve is very stable. See how stable the valve is. We always do quickly inflation of the balloon. In this case, there was a delay in pulling back the pigtail, but there's not a problem. While the nurse was adding 2 cc to the balloon, we made a aortography just to check, just to documentation, and you saw a huge amount of regurgitation to the left ventricle, but it was expected. Then we went to the second step. We put the balloon into the ventricle. Here it's too deep. We pull back a little, and then we made an inflation with 2 cc added. So I'm gonna repeat just to show you there is no contact with the balloon with the sinotubular junction, the ring. I'm going to show you. Please pay attention. You're going to see how the valve increasing its diameter with the second balloon. So you pay attention, and now you can see inflation and expand the valve. So we have the control images showing a very good result with trace of regurgitation. The echocardiogram showed a mean gradient pressure of 5 millimeters of mercury, the peak gradient 11 millimeters. The outcome, the patient was extubated in the operating room, discharged home on the second postoperative day. The creatinine level was quite the same as the first day, the admission day. And a final message, I'd like to say that the cardiovascular surgeon must be prepared to predict, detect, and manage complication in TAVR. Training is essential for a successful procedure. Image quality and optimal analysis are crucial for anticipate potential complications. Implantation of a balloon expandable valve, Edwards SAPIEN 3, can be safe in patients with challenging anatomy. And if you fail to prepare, prepare to fail. That's all. Thank you very much for your attention.
Eloy, thank you. We are now starting our discussion. I have a question to Dr. George, and I would like to also see the opinion from Eloy also to the same question. Really, in fact, it's two questions. Dr. George and Eloy, what are your proportion in the real life of TAVR versus SAVR in your centers in Colombia and Campinas respectively? And regarding to SAVR, what are your proportion of minimally invasive surgery nowadays? Starting with Dr. George, please.
Thank you very much. And again, I also wanted to thank everyone for wonderful presentations. Those were really nice cases with a lot of interesting aspects. In terms of our volumes, we have probably in 2014 or so, we're very early in adopting TAVR. We were one of the main sites. We ran the partner trial from here. And so we were treating patients with isolated aortic stenosis with TAVR very early. So our proportion of isolated AVRs dropped from about 2014, 2015 to do, again, we were a very busy center doing 800, 900 AVRs, and we only, we're probably doing 200 now, something like that. So our isolated aortic valves are treated probably 75 to 80% TAVR, and 20 to 25% surgical. The surgical patients are patients who don't have good anatomy for TAVR, meaning patients who have bicuspid valves, patients that are younger, and I'm excluding patients with aortic insufficiency. These are only AS patients. And I'm not including patients with multi-valve disease or coronary disease. Those patients preferentially are treated with surgery below the age of 75 or so. So in terms of isolated aortic valve disease, probably 3/4 are treated with TAVR. In terms of the proportion of patients that are treated with minimally invasive approaches, I would say that probably 75% are treated with some sort of mini incision or mini T approach. We occasionally will do a right anterior thoracotomy, but because of, I think, patient discomfort, we've had some patients with healing and some persistent pain, and so we only do that rarely.
Thank you. Eloy, please.
Our evolution of TAVR versus SAVR in Brazil is a little bit different. So we're going to use basically in TAVR in high risk patients. That's what we're doing. But we began a program of TAVR some years ago, and we want to see even just using TAVR for high risk patients, we are increasing year by year. We can see that the patients are coming and we are increasing proportionally. It's an important number of patients that we're increasing since 2016. Every year we increase, but Unfortunately, you know, in Brazil, it's different for the system. We just use it in high-risk patients. And then with the number of server that we are using also in mini sternotomy. We are increasing our program of mini sternotomy, especially with rep deployment valves, like Intuit and Percival. So that's an option that we can give for the patient this kind of situation. The rapid deployment valves, it's very good for a mini sternotomy. It's a quickly, and the recovery is so fast. That's our experience here in Campinas.
Okay, thank you, Dr. Costa. I would like to ask Dr. Gaiotto. Gaiotto, in the case you presented, are you using any type of anticoagulation in this patient for 3 or 6 months, a short period anticoagulation, or none?
Okay, we recommend to use only aspirin through 6 months only. After 6 months, stop everything and without anticoagulation for aortic valve replacement with this kind of valve.
Okay, but you are using anticoagulation for 6 months in
aspirin, only aspirin.
Ah, only aspirin. Okay.
Only aspirin. Only aspirin.
Okay, thank you.
I would like to ask Dr. Sérgio. You presented a very nice case of combined procedure, cabbage and deployments. I would like to ask you about the AV blockage and rate and new pacemaker in the outcomes, and also your experience with minimally invasive and rapid deployment valve. Please, Dr. Sérgio.
Thank you very much, Dr. Carlos, for the question. The previous cardiac rhythm, it's very important. If you have some block before the surgery, probably you are going to use a pacemaker after it, okay? But it's not, in our experience, we have 4% the incidence of pacemakers. We don't have a great experience. We have just around 60 cases of Intuit in our institution. And we have 4% of pacemaker that are related with the prosthesis. Because if you have an indication before the surgery, it's not considering these statistics because the patients are going to put the pacemaker. Regarding the minimal invasive, yes, it's our preference approach. The minimal invasive surgery with isolated aortic valve replacement, and we use the mini sternotomy. We don't have experience with the anterior chest way, but all of the cases with isolated we use the mini sternotomy in all the cases of isolated aortic valve replacement. And in some cases, we use the Intuit, of course. It's a very, very nice because in this case, it reduces so much the cardiopulmonary bypass and clamp times.
Okay, thank you, Dr. Almeida. I would like to ask Dr. George and Dr. Cledicyon, have you ever had any aortic dissection during a TAVR procedure?
Yeah, I can answer. We have certainly had aortic dissections. We've had probably 30 to 40 major aortic injuries over our time period. These can be dissections, these can be perforations of the abdominal aorta, the thoracic aorta. We've had annular root ruptures. So I've operated on every single one of those over the last 10 years. And the mortality is at least 50%, but we have certainly saved people. One of the reasons that we are able to save people is that all of the rooms that we do these procedures in are hybrid rooms that are fully staffed by not just, you know, cath lab nurses or cardiology nurses, but true operative nurses. And so when we've had issues, when we've ruptured an aorta, when we've, ruptured an annulus or had a dissection, we're able to open the patient. We're able to use the cannulas in the groin. We're able to switch out the E-sheath. I've even put the aortic cannula through the E-sheath, and I use all of the access percutaneously to go on bypass, and we open the patient up right there and right then and there. We have perfusion in the room, and so I'm sure we've saved some people because of that. But certainly we've had dissections before. I actually operated on a dissection from a TAVR that we had a delayed diagnosis. This was about a month ago, where we deployed a valve, a self-expanding valve. It actually embolized and caused a dissection, and then 4 days later she came back and we discovered the dissection, and I operated about 4 or 5 days later.
Okay, thank you, Dr. George. Dr. Cledicyon.
Yeah, we didn't have our dissection, but we did have rupture of the aortic root. It's catastrophic. It was in the beginning of our experience. It was part of the planning. As I told you, we have to plan it. We failed in planning that case. It was very calcified valve in the aortic root. We used, in this case, an out-expansible prosthesis, but it was not the problem, the prosthesis. We need to do a post-dilatation, and we go over what the limit. We passed the limit. So I think it was the same thing. Fail to prepare, prepare to fail. I think that case should be stopped. There no indication, maybe because there is a limit. I believe that even for TAVR, there is a limit. Some kind of calcification, a huge calcification of the valve and the aortic root, it's the limitation. This material is not prepared for every case. I think almost every case, but in this situation, we had a catastrophic situation. We deployed the valve. It was not good. We have to balloon and balloon again until we had a rupture, and the rupture is equal to that, and the patient died in the operating room. Okay. It was in the beginning. I think it should happen again. Yeah, but if you plan, we have a chance not to repeat this mistake.
Okay. Thank you, Dr. Cledicyon.
We have a question from the audience. For all the speakers, I would like to see all the speakers regarding to double valve replacement, mitral and aortic. Do you have experience with the Intuit implants in aortic valve and also another valve in mitral, or you don't use this kind of device when we have a double valve procedure? Starting with Dr. George, please.
I don't have experience of doing double valves with Intuit. I imagine the Intuit balloon would interfere with the mitral valve struts, and so I would be concerned about you using that. So I have not used that in that situation.
Dr. Sérgio?
We have 6 cases combining mitral and aortic valve. And some rules is very important. First of them is that you must respect the distance between the mitral annulus and the aortic annulus. It must be more than 0.8 centimeters. It's very important. The echo shows this very well. Second, if you use pledgets in the mitral prosthesis, between 1 o'clock and 9 o'clock, put these pledgets in the atrial side, not in the ventricular side. This is also very important. And it is important, we used to put the mitral, the posts of the mitral valve at 10 o'clock and 2 o'clock. If you are going to use the Intuit, just rotate a little bit, put 1 o'clock and 9 o'clock. It's going to be better. And also with, if you repair the valve, it's not going to be a problem if you respect the distance in the mitral and aortic distance. That's I can show to you about this.
So when I have mitral and aortic procedure together, I prefer to use common valve, not to use intuitive. I believe that is easy, the procedure. I never use intuitive and mitral valve together.
Yeah, we have our experience. We have a small experience one case, but the case that we planned, we also had a second type of valve in the operating room. In case of after putting the mitral valve, we had problem with the intuitive valve. So we had a second option, as Gaiotto said, because we could change. After putting a mitral valve, can change the situation. You cannot able to put intuitive after. So we have a second valve in the operating room in case we have to need our plan.
Okay, another question from the audience to all speakers. What the opinion of doctors about TAVR in low-risk patients, especially when the patient asks for TAVR instead of SAVR? Dr. George, please, could you start?
That's a really, really good question. And that's something that we face every day when we get a 65-year-old healthy male or woman who comes in who would be a great, surgical, minimally invasive in and out of the hospital in a couple of days with a great 15-year prognosis with the surgical valve, and they want TAVR, and then their anatomy is good for TAVR. And so at the end of the day, the patient can decide, we give guidance as to what we think is medically acceptable. We tell patients something that's medically safe and medically unsafe. And so if we think the anatomy is good for both options, we tell them, look, these are the pros and the cons of each procedure. We don't think that they're medically unsafe. If they're medically unsafe, we won't perform the procedure. Let's say it's a heavily calcified bicuspid in a surgically acceptable patient. We won't perform that TAVR because that's unacceptable risk-benefit ratio for us, and we'll only perform SAVR. But if they have acceptable anatomy and it's both medically safe and it comes down to a patient's autonomous decision, then we try to give the patients all the information that we can for them to make a decision. Patients have individual priorities. Maybe it's a recovery. Maybe someone's spouse is sick with cancer and they're taking care of them and they can't afford to be be in the hospital recovering for a long period of time. Or they have disabled children and they have to lift up their children and they can't, face a recovery from a sternotomy. So everyone's a little bit different, and they have to accept the compromises of potential reduced durability with the TAVR, potentially a more difficult reoperation, a higher pacemaker risk, or if they're worried about stroke, if they've had a stroke in the past, we know that the stroke rate is lower in TAVR, and maybe they'll pick TAVR because of that, or maybe they're worried about durability, or maybe there's coronary disease and therefore they pick surgery, and they're willing to take a longer recovery, and that's what makes sense for them if you plan it out for them. So we try to give them that guidance and then let them decide, and we're very, very clear about limited durability information for TAVR and the difficulty in the reintervention in terms of a reoperation. And as long as we document that and we make that very clear, it's up to the patient to decide.
Patients with low risk in Brazil is we usually don't put TAVR in patients with low risk, especially because we have we have the health insurance that don't pay for that, but some patients ask about, and it's a problem because they don't pay. It's just a way of not, so we don't have this kind of patient. I know many patients come to us and say, doctor, I don't want to open my chest. I prefer that little valve. I like the same that Mick Jagger has. And I say, no, it depends. Each case is different. We explain the situation, especially the payment situation here in Brazil. But in low risk patients, we don't have cases where we put TAVR.
My opinion, Sérgio, sorry, And my opinion is very similar with the Isaac opinion, but we have a difference. I strongly suggest to not put TAVI in young patients because we have a prosthesis, a bioprosthesis that permit a long durability, like Inspiris resilia. Maybe 20 years, it's possible. And the estimative is more than 20 years. So you put one Inspiris resilia, 23, 25, or 21, because the ring is open. In the future, it's possible to perform only one TAVI, and the patient goes to end of your life with a very good quality, only with one sternotomy. And I believe I have not a good experience to redo operation in TAVI patients. To remove TAVI and to perform as aortic replacement is very difficult. If the patient chooses the TAVI way, he will be always TAVI. Because if I have a patient with TAVI to perform a redo operation, I send to Manuel or Bruno Botelho to perform the operation because it's a very difficult procedure. And in all patients, I perform aortic root replacement or dental de bono or Cabral. It's difficult. So I strongly suggest to not put TAVI in young patients. This is my opinion.
No, I would agree. I would agree. And we tell patients exactly that. And the market is very competitive, and you're going to see this soon. And that's the interesting part of the phase that you're at right now. Soon, you're going to get to intermediate risk and low risk patients that potentially get approved by the government, I assume, at some point. And so you're going to have to get to an understanding with patients how you can convey that kind of information, how you can convey that message to them appropriately without alienating them. Because what happens here is we have enough of a competitive market, and you may have some of that as well in Brazil, where they'll come to us and they say, look, this is what I want. They go on the internet, they know about Inspiris, they know about Sapien, they know about Evolute, they know about everything. They know more than we do, you know? And they come in and they say, I want this, this, and this. And you tell them, look, this isn't a good option for you. This is not in your best interest, and this is why. And they say, okay, thank you very much. And they go down the street, and they go to the hospital down the street. And they just keep looking, and they'll go all around the country. They'll go to Mayo Clinic, they'll go to Cleveland Clinic, they'll go to any clinic that's out there that'll do it.
I'm very happy because my patient goes to Mayo Clinic and return to Brazil to operate for us. We're very proud of this.
Well, my opinion, it's very important to separate low age and low risk. I think this is very different populations. And I totally agree with Fábio that I think for low age, let's call it like this, I prefer to put TAVR. And of course, in a high age with a low risk, I think it's very nice to put a TAVI, like Dr. Isaac told us. But we must know how about TAVI is going to perform in the low risk, low age patients, because it's different. It's completely different kind of patients. We know about our prosthesis, surgical prosthesis, long-term durability, and I believe so much in the Inspiris. I think it is a very, very nice project. And that is my opinion. Sometimes we put in the same comparison the low risk patients with patients in high ages, different. It's completely different from low ages.
I will say one thing, you know, to be fair, and I'm not defending TAVR, but we have about as much long-term durability information with Inspiris as we do with TAVR, which is not that much. So I think we have to, and that's one of the good things about all of these trials. We're going to follow all of these devices and valves for a long time. And I do think that Inspiris will last 15, 20 years. But I think there will be some of the valves that we put in probably don't last you know, 15 years. We tell patients certain valves last 15 years and they don't. The mitral valves, you know, mitral valves is a huge problem. Rheumatic young mitral patients, we put tissue valves in them and they last, you know, we're happy if they get 8 years, frankly.
Yeah, one thing that I'd like to say also is I'm not concerned about the durability of the valve, the TAVR in young patients. The problem, in my opinion, is the calcification in young patients is different from the calcium that we see in old patients. So this kind of calcium is more hard. I don't know how to break, it's complicated. So the calcium in young patients, the patients of 50 that has a huge calcification is different from patients 80, 70 years old. So in my opinion, it's not only the durability of the valve, but what kind of damage you do to the aortic root trying to balloon all that calcium.
Okay, I have a question to all the 4 speakers. In patients, in low-risk patients with a small aortic annulus, what do you indicate? TAVR plus aortic root enlargement, a rapid deployment valve, or a TAVR? We can start with Eloy, please.
Small root?
Yes.
Small root, nowadays, my first option is a TAVR. That's my
even in low risk.
Depends how young is the patient, okay? But in small patients, my first option is TAVR.
My opinion is if you are planning just one procedure for this patient, I am very comfortable to put a rapid deployment valve because it's going to be very low the gradient. But if you are planning more than one surgical procedure, I prefer to put to make an enlargement and put a bigger prosthesis.
Yeah, I think if the patient is going to outlive their valve, then I would prefer to either do, and they don't have good valve-in-valve anatomy, then I would prefer to either do a tissue valve with a root enlargement or a mechanical valve. If the valve is going to outlive the patient, then a TAVR is a good option.
I prefer to do the enlargement valve. It's not difficult. It's 20, 30 minutes more than the valve procedure to do the aortic valve ring enlargement. Is my option.
Okay, thank you. Another question from the audience. In very young patients, 20 to 40 years old, the use of mechanical prosthesis, do you think that could be a definitive solution with good hemodynamics in patients very young or all? Please, Dr. George.
Yeah, these are really tough patients, you know, and when you're talking about 20 years old, you're talking about inevitable multiple re-interventions. And so it's picking your poison. Do you want to deal with Coumadin and the 0.5% risk of some kind of major bleeding event or thromboembolic event versus the reoperation re-intervention aspect of it? I think the one procedure that is not been mentioned that is for patients that are that young is the Ross procedure. It is a good option for patients with the right anatomy without concomitant root dilatation and who have aortic stenosis and not insufficiency as their primary pathology. It does offer the potential for a 20-year outcome. Although re-interventions on both the left and the right side, as you get older, are more common. So it is potentially a solution for the younger patients to get them to the next level. And at that point, then, offering reoperation is an option. My philosophy for the very young patients, I think calcification somewhat depends on their biology. And I'm willing to give them a shot, give them one shot with a tissue valve. And if they fail with the tissue valve, then I move on to a mechanical valve. there are occasionally patients out there that get 20, 25 years out of a tissue valve, young patients. And it's not that common, but they're out there. And it's probably due to some biologic interaction that we just don't understand. If a patient will get 15, 20 years out of it, then they've gotten to 50 or 55 maybe. And then you can, you know, figure out what kind of reintervention, whether it's TAVR to extend the life of that and get through with only 2 reoperations. And so I try to, you know, think about it in that aspect and give them a shot with the tissue valve. And if it fails, then go to a mechanical valve.
It's a very young patient, especially if male. I think there is the problem is almost resolved. We have a new generation of mechanical valve for males, like the Onyx valve. So we have, don't need to anticoagulate so much as the old valve, but it's female, it's a problem. I think for a very young female, there is no valve that's gonna last a long time. It's a problem. If it's a male, so I can go no problem with a mechanical valve like an Onyx valve. But a female, it's a big problem. You have to talk to the patients, and it's not easy to decide in female very young.
I believe that if you have no contraindication for antithrombotic therapy, I put a mechanical valve with a very nice procedure, mechanical valve. But if you have a problem with anticoagulation or a young woman that wants to pregnancy in the future, I put, like Dr. George told us, a biologic valve and after a mechanical valve in the future.
I totally agree with Dr. Isaac and Fábio and Eloy. I think the most important thing is have the patient's commitment about the Coumadin. It's very difficult sometimes to have a long period of using Coumadin. This is probably in the option that Dr. Isaac gave to us. It's a very, very nice choice. But in other way, we can use procedures like the Onyx that, of course, you need the Coumadin in lower doses, and of course, the risk of it reduce. That's my opinion.
We are close to the end. I would like to do some final remarks. This is another important webinar that illustrates how we are surgeons. We are learning in terms of new valve types and new technologies. This is the second webinar regarding to aortic valve replacements, and it was excellent as the other one. So I would like to thank myself, and in the name of the Brazilian Society of Cardiovascular Surgery, Edwards Lifesciences, for the support to this meeting. And I would like to thank you all the speakers for your excellent presentations and the support for this excellent meeting. I pass for Bruno.
Okay, thank you. I'd like to thank you all speakers for joining us today. And on behalf of the Brazilian Society of Cardiovascular Surgery, I'd like to thank our president, Dr. Eduardo Rocha, and our education director, Dr. Rui Almeida, for the organization of this meeting. And I'd like to thank you, Edwards Lifesciences, for its support to make this webinar happen. And good night. Thank you very much.